Last week we celebrated my HoLEP number 1000 and we had the idea of putting this procedure online, of course with permission of the patient. Now the patient is a male of 78 years old. He has severe voiding complaints while he was already taking drugs for his prostate problem. On ultrasound he had a prostate of around 100 grams, which was not suspicious for prostate cancer. In this video, I'm using a Quanta high-power holmium laser and a morcellator of Richard Wolf. I'm using an Olympus laser resectoscope. The technique that I use is an HoLEP en bloc technique, which was described by Professor Gomez Sancha, which I'm very grateful. So here you see me looking inside the bladder, which looks trabeculated, and I'm having a look at the orifices and to see if there are any suspicious findings in the bladder, which are not. Now I'm looking for the junction between the mucosa on the adenoma and the mucosa on the sphincter, and there I make this incision as was described by Professor Sancha, which is called the white line, which is actually a separation between the mucosa on the sphincter and the mucosa on the adenoma. So we circle around this white line, and then if it's not bleeding too much, we already try to deepen it a little bit in order to make sure that the sphincter mucosa is preserved as much as possible. So in the beginning, we're not really looking for the surgical plane between the capsule of the prostate and the adenoma. We're just making this incision and we're trying to deepen it a little bit just for preservation of the sphincter. So here we're already trying to find the surgical plane and having a look. So here you see it popping up a little bit. This is where you find the plane. And then we do the same on the other side of the prostate. So there you see the plane coming up. We try to use as little as possible mechanical force, although sometimes a little push is allowed in order to find the plane. So here we're actually looking for and finding the surgical plane at the left side of the prostate. So there's the plane, but here's a small nodule which I will try to take . Okay, there's the plane. Okay, you can see the plane nicely developing here. And now we go a little bit to the medial side of the left lobe and trying already to undermine the median lobe a little bit. And this will help us in creating the connection with the other side of the dissection, which we will start soon. So here we're already undermining the median lobe a little bit, as you can see. Okay, now we're moving to the right side of the prostate And again, we're looking for the plane next to the verumontanum, which is coming here. Here you can see again nicely the surgical plane. And again, we're working medially to go under the median lobe, which will allow us to make an easy connection between the dissection on the right side and the dissection on the left side. Okay, so this is the verumontanum. Now you can see the dissection at the right side, dissection at the left side, and now we make the connection between the surgical planes. So all the fibers that run longitudinally have to be cut, and now we try to establish one nice posterior dissection plane, which is very important for the rest of the procedure. We really want to make one plane. Certainly at the posterior side, well, actually everywhere, but at the posterior side of the prostates, there are multiple surgical planes available. So it's important to have already from the beginning of the procedure one surgical plane and one line which you can attack to proceed easily in the procedure. So at this moment we have one surgical plane posteriorly, and now we're working on our way in the direction of the bladder neck, in the direction of the bladder. So you have to feel a little bit how far you can go, as long as the instrument can move easily without the need of giving force. You can proceed your way at the posterior side of the prostate. Now we have turned the instrument and we have put a laser fiber at 12 o'clock, which allows us to work a little bit easier and to be able to lift the tissue. So as a HoLEP procedure is a very anatomical procedure, it's important to give traction, and it's important to see the surgical plane, of course. So we're still working and evolving on this posterior plane and working our way to the bladder. Here we're dissecting a little bit at the right side of the prostate. Okay, so now we have dissected the posterior plane quite far, which is nice. So here I'm going up a little bit at the left side of the prostate. So I'm already thinking about making a connection later at from the posterior side to the left side. Okay, so that's far enough. So now we go back here. We have a look at the mucosa on the sphincter, and we make a cut right on the adenoma, right under the sphincter mucosa. So we deepen the incision on the white line, and we make sure that we connect with the posterior line of dissection which was made earlier. So this is what Professor Sancha calls axis incision, and I can only agree that this is a very good way of making sure that the sphincter is nicely preserved. So we cut a little bit on the adenoma right under the white line that we created in the beginning of the procedure, and we go up with this incision right up until 12 o'clock. So now I'm doing this also at the left side. So I'm making this axis incision at the left side, right under the white line, which we have made in the beginning, and I'm already extending it until 12 o'clock. Okay, and this creates the connection with the posterior incision that we have made in the beginning of this procedure. That is a small hemostatic burst of energy. And now we are again working on the apex in order to free the apex completely, so that we have a nice early apical dissection of the prostate. Okay, there's a little bit of adenomatous tissue still hanging there, so I will probably here try to remove it by vaporizing it a little bit. Okay, now I focus again on finding the plane at the left side and connecting it with the dissection plane at the posterior side. Now we're mobilizing the adenoma by following the surgical plane at the left side, and now going steadily up in order to get this complete apical release. You can see that the holmium energy, the bursts of holmium energy, really open up the surgical plane nicely. Okay, we're following our way right until the anterior portion of the adenoma. Okay, and now I'm trying to connect with the other side. Okay, this is the right side of the prostate, of course. Now I'm working my way on the lateral right side of the surgical plane between the adenoma and the surgical capsule. Working my way in the direction of the bladder neck while making sure that there's a connection with the posterior side, of course. Okay, now I'm trying to go up. Again, you can see that the holmium energy really nicely opens up the plane. Here I'm trying to make the connection with the other side. Okay, probably it's there. All right, so there you have it. So we made now a complete connection. So this means that we have the sphincter completely free now, that we have established a nice apical release. And now we're dissecting our way on the anterior side of the prostate. I'm making the connection with the right side here. And just working our way in the direction of the bladder, of course. Here I have some small hemostasis to do. Okay, that was a small bleeder. That's done. So now, because the apex is completely released, we can really proceed in the surgery while working around our way completely around the adenoma, which is very nice and intuitive, and it really allows you to give a lot of traction on the adenoma in order to see the plane in an ideal way. Also, it's an advantage that the sphincter is completely free. Here you see that there's a little bit of adenoma tissue hanging there. So I will try to work my way around it in order to remove as much as possible. So I have like a little, yeah, I have to correct it here a little bit, as you see. So I was in the adenoma there, and I tried to work around it in order to remove it, the adenoma, as completely as possible, as you see here. Yeah. So I have to make a small correction of the plane that I didn't dissect in the ideal way from the other side. But there's no problem. You can just work your way around it. Yeah, you see it here that I have to make a small correction there. Yeah, that's what's happening, and of course I have to make a connection now. So, problem solved. And now we can proceed to the bladder. So there is the bladder coming. You can see this typical appearance of the bladder neck fibers, the longitudinal bladder neck fibers. So I'm sure that the bladder is right after these fibers. So at this stage, I'm not really attacking the bladder immediately. So I mean, I'm not really going inside the bladder immediately, because I want to keep some of the advantages of working in an en bloc approach. That is that it's very in a hemostatic way. If you don't open up the bladder immediately, we can work in a very small, confined way. And also, if you just wait with opening the bladder completely, for me it's a little bit more intuitive. The prostate is more in its natural way, so I have a better overview. So I just wait with opening this last bladder fibers completely. Although I know where the bladder is now, of course, especially from the anterior side. So I just extended the section here a little bit. Right until I feel that I have to give too much force. You do not want to push the prostate, as Dr. Lerich has taught me in my fellowship with her. Be gentle to the prostate. So that's what I'm trying to do. And now, as I have worked my way around it sufficiently, I will open the bladder anteriorly, and I will do it from 9 o'clock just until 3 o'clock. When I have done that, we will have a look inside the bladder and find the orifices in order to make sure that we do not injure them while working further. Here's also a little bit of adenomatous tissue hanging there, but it's probably of no functional importance. Okay, so I'm really opening the bladder neck now and entering the bladder. I do this always from 3 o'clock until 9 o'clock. Not further to the posterior side, because first I want to know where my orifices are. But I do want to open completely from 3 o'clock until 9 o'clock in order not to tear off the tissue at the anterior side. So now I have a look at my orifices. This is the right orifice. And now let's have a look at the left orifice, which is right there. Yeah, there's some calcification on the mucosa. So what I do then is I put my fiber at 6 o'clock and I work my way down. I know where my orifice is at that side and I work my way down. I try to follow the contour of the bladder neck as nicely as possible, while of course making sure that I do not hurt, I do not injure the orifice, and I try to extend this incision from the lateral side as posterior as possible, and this makes sure that the tissue is actually only hanging at the capsule at the posterior side. Okay, I'm checking the orifice again and again to be sure that I do not injure it. Okay. And here, of course, you have to be careful that you do not undermine the bladder neck. And you want to be a little bit closer to the adenoma. Okay, so that was the left side, and now I go for the right side, where I do exactly the same, of course. So again, I put my laser fiber at 6 o'clock, and I cut down to the posterior side, following the contour of the prostate. Of course, you want to be sure that you do not hurt the orifice there. So have a look. So that's what I do, and I go down. Okay. Well, there's some small hemostasis to do. And again, you want to be sure that you do not undermine the bladder. So try to go a little bit closer to the adenoma. There's no problem if you leave a bit of adenomatous tissue hanging there, of course, just a little bit. And now actually I have made some kind of median lobe out of the complete prostate, and now I try to connect both lines of dissection. I'm working my way slowly up through to the bladder neck, as you can see here. And we're almost done with the enucleation phase of the prostate. Okay, so this is the last phase of the enucleation. So the adenoma is almost completely released. Yeah, I check the orifice again and again in order not to injure them. Well, the adenoma is completely released and inside the bladder now. So now I have another look at the orifices. I check if I have some hemostasis to do in order to be able to go for a safe morcellation in the next phase of the procedure. So so there's not a lot of bleeding, so it's possible to go for the morcellation quite soon. Yeah, there's a little bit of adenomatous tissue hanging there. That was the bridge that I had to create in order to make up for the small small mistake I made there. So this is completely corrected now, so that's fine. A last check of the hemostasis. Okay, and it seems that we're good to go for the morcellation. So this is the sphincter, which looks very nice, nicely preserved sphincter mucosa. So then we can be confident that this patient will have no stress incontinence after the procedure. Okay, so now it's time to remove this tissue and to morcellate. So now I'm changing the instruments. Of course, I'm putting away the laser resectoscope and I'm taking the morcellator scope. Okay, so that's there, and here I'm in the bladder with the morcellator. The bladder is now completely distended. I'm putting 2 inflows on the bladder in order to be able to go for a very safe morcellation. It's very important now that the nurses check that the saline bags that we use are not completely empty. So in the beginning of the procedure, during the inoculation, it's a bit annoying if the irrigation is empty, but it's not very dangerous, while in this phase it really is. So we have the whole team actually trained to check the saline bags during this phase of the procedure. So now the tissue is being morcellated nicely. I'm inside the bladder at this stage of the morcellation. Mostly I start inside the bladder, and at the end of the morcellation I try to take the fragments into the prostatic fossa in order to be able to morcellate very efficiently and safely. So I have a nice visualization. There's not a lot of bleeding. I see the black triangles at both sides of my morcellator, so I know I'm safe, and then I just keep morcellating. Okay, we're almost done. This part of the prostate looks a little bit more fibrous, so this probably is a little bit more difficult. Okay, so the tissue, yeah. So, okay, yeah. Now it tends to drop off. So what if it drops off, if the small tissue fragments drop off, I try to drag them in the prostatic fossa. Here I'm actually still working inside the bladder. yeah, this last piece surely looks a little bit more fibrous, so that will be a little bit more difficult to morcellate. When I look at it, yeah, okay, so probably now I'm trying to go inside the prostatic fossa. Yes, I would, when I was looking at the video, I would advise myself to do it a little bit sooner. Yeah, because this harder parts of the prostate, I think it's very easy to do it inside the prostatic fossa as I'm doing now. Yeah, so I grab them or with suction, and then I bring them in the prostatic fossa. Okay, so that looks very good. Probably the morcellation is completely finished, so I'm having a last look to see if I'm completely done. Okay, so this looks good. Again, the sphincter mucosa looks nicely preserved, so I'm happy with this for sure. Okay, so then the morcellation is done. And then I switch to a classical reusable coagulation loop or resection loop, but I use it only for coagulation. Probably it's not a necessary thing to do, especially not in an easy and fluent operation such as this one, in which I did not really have any problems, especially no bleeding problems. But I think you have nothing to lose with having a look with this resection loop. Yeah, of course it takes you a couple of minutes, but it's a reusable loop. Sometimes you see a bleeder that you are happy that you have coagulated it. I think it allows me to remove the catheter very soon. In most patients, we can take the catheter out at the first day postoperatively. To be honest, I have never tried it in another way. I mean, I've never finished the procedure without having a look with this coagulation loop. So I do not really know if I can do it without. Probably we can, especially in procedures like this. But I have the feeling that if things go well, I prefer to do it in this way, and I feel safe with this. Of course, you do not want to give too much energy to the capsule. Okay, so this looks nice. No bleeding problems. Yeah, that's a verumontanum. There are always some small bleeders around the verumontanum, so I try to take them. Yeah. Okay, so that was it. So now we place a catheter, and we can remove it normally at the first day after surgery. And in this patient, it was done, and the rest of the postoperative course was uneventful. The patient went home the next day after the surgery. This was only last week, this procedure, so further follow-up with this patient is scheduled. I still have to see him, of course, at the first postoperative consultation. That will be in a couple of weeks. So I would like to thank all my colleagues, my co-workers, the nurses, the people from the secretary. We are very, very important for us, and thanks for watching this video.